In this video, a two-stage surgical technique for management of giant retinal tear with severe PVR will be described. A 20-year-old male patient presented to us with loss of vision in his left eye. The patient had sustained a penetrating injury with a wire 1 month back, for which corneal perforation repair was done at some other hospital. A giant retinal tear of greater than 270 degrees with an inverted flap and extensive PVR changes of grade C can be seen. The retina is folded on itself and can be seen to be displaced nasally. The bare choroid is seen on the temporal side. A vitrectomy was being performed, especially releasing all the vitreous attachments at the edges of the giant retinal tear. At the nasal end, the site of perforation was noted, with some incarceration of retina. Vitrectomy was done to relieve the traction at the site of the perforation. A small PFCL bubble was inserted to unfold the retina and also provide some surgical space for membrane dissection and release of the proliferative membranes. Extensive PVR and retinal shortening with folds involving the macula were noted. Proliferative epiretinal membranes are removed with the help of an ILM forceps. Despite all efforts and removal of the proliferative membranes, the nasal retina was severely contracted and not mobile. So, relaxing retinectomy was performed nasally. The fovea was observed to be displaced inferiorly due to severe PVR involving the posterior pole. Retinal fold involving the macula was also noted. ILM peeling was attempted to further reduce the traction at the macula. The internal limiting membrane was extremely thick, edematous, and firmly adherent to the underlying retina. Limited ILM removal was achieved with great difficulty. Once the retina was sufficiently mobile, more PFCL was injected to completely flatten the retina. This was followed by 4 to 5 layers of endolaser, 360 degrees around. At this point, PFCL was decided to left in the eye as the chances of redetachment and slippage of the giant retinal tear were very high. Residual visible epiretinal membranes were removed. This was followed by PFCL air exchange, and silicone oil was injected in the end. With this two-step technique, we were able to achieve successful outcome in a case with no hope. PFCL tamponade for few days not only prevented the slippage of the giant retinal tear and redetachment of the retina, but also helped the retina to regain its near normal healthy state. Six weeks post-operative, the best corrected visual acuity improved from PL positive to 6/60. The retina is well attached and appears in a much better state. In such poor prognosis cases of giant retinal tear with extensive PVR, this two-stage surgical technique may be attempted. It may help to salvage some eyes, as in our case.